All right, I think we'll go ahead and get started. So welcome to the August SIG meeting. I'm Rachel Petz. I'm one of the co-chairs of the Ped SIG. Our other co-chair, Chus, is out for today, so it's just me. We have two special guests today, Tyanna Snider and Rebecca Kirchner, who are going to be joining us from Nationwide Children's Hospital to talk about the Autism Spectrum Disorder Pathway that they created. So we're super excited to hear from them. Before we get into the presentation for today, I have a few announcements that I want to go over. So one of the announcements is the awards election is actually has been extended until August 13th. You may be aware we actually have a new award, a Pediatric Integrated Care Award, and some of our very own SIG members have been nominated. So please consider voting. You have until the 13th. In a little bit, I'll post the link to the site where you can do the voting. And I believe they'll be doing kind of the award celebration at the conference for those who get the award. And speaking of the conference, it looks like the conference schedule is now up. There's lots of pediatric focused sessions. They're labeled PEDS. We are having also an extended learning opportunity that the SIG is promoting. It is on building primary care school collaborations for the promotion of youth resilience and the prevention of suicide. So look out for that on Thursday morning. And registration is open for the conference. Jackie, is there anything else related to the conference? I think she's on the call.
Yes, I am on the call. Sorry. Just if anybody wanted to do any discussion groups that had a PEDS focus, you can sign up for one on your conference registration or just shoot me an email.
Awesome. Thanks. And the other announcement is the SIG, we're starting up a mentorship program. So we've historically had, I guess, a mentorship program informally in the past, and now we're really trying to put together a formal process for individuals who are seeking mentorship in kind of different areas of practice. It could be in research, it could be administration, it could be training. So we're going to start to kind of roll out that process. And first, we're really interested in individuals who would want to serve as a mentor. And again, we're seeking individuals, different areas of expertise and practice, et cetera. At this point, we're just looking for those who are interested. There's no kind of final commitment, but if you potentially are interested in serving that capacity, there's a form that you could fill out. I'm going to post it in the chat in a bit. You could also reach out to Chus or myself if you have any questions, or if you want to express some interest. So we're recruiting the mentors now in hopes to kind of start the match process potentially in October or beyond. So if you are interested in mentorship, also be on the lookout for that, and we'll have you kind of sign up at some point. And lastly, I think that's it. I think that's it for the announcements. But if you have any job openings, as always, place them in the chat. And awesome. Thank you, Tanya. Your willingness to mentor. All right, great. So at this point, I am going to pass it on over to Ty and Becca. As I mentioned before, they are from Nationwide Children's Hospital, and they are going to be speaking about their Autism Spectrum Disorder Pathway.
Well, thanks so much for inviting us to present at this Ped SIG meeting. We're going to try and keep this relatively brief, but we're going to be at CFHA in October. So if you have more interest, you can definitely come find us there. And I'm going to kick us off. And let me just share our slides really quick. I can. There we go. All right. So Becca and I are going to be talking a little bit more about our autism pathway that we developed within our integrated primary care setting. And so our agenda really is just to kind of go over our kind of current flow in the process that typically would take place here at Nationwide Children's Hospital, then tell you a little bit more about our specific IPC ASD pathway, which we're just doing those evaluations in the primary care setting, and then to talk a little bit more about next steps. But really what we know and kind of how this pathway really came about is because we are caring for a lot of children with developmental delays and autism spectrum disorder. The CDC's new estimates reveal that about 1 in 36 children within the United States really meet criteria for a diagnosis of autism or an autism spectrum diagnosis. What we also know is that behavioral health agencies really nationwide are overwhelmed and they have really long wait lists, really anywhere from probably 12 months on the lower end of the wait list to maybe 18 months all the way up to 2 years on that higher end. And because of this, we know that it can be a little bit frustrating for patients and families that are presenting to primary care with these concerns for their children potentially having an autism spectrum disorder, because the earlier we are able to kind of make this diagnosis and get children linked with interventions, we know that that's really associated with positive long-term effects on symptoms and skills. So our traditional pathway here at Nationwide Children's Hospital, we are in Columbus, Ohio, and we're blessed to have a really large behavioral health system and a lot of other resources at our disposal, but yet we're still having some of these concerns and some of these challenges with access. So traditionally, a patient might be seen in their primary care setting. There might be concerns for an autism spectrum disorder at that time. The pediatrician or PCP would place a referral to our Child Development Center, which is our autism affiliated center here at Nationwide Children's Hospital. The family then has to go through an intake process with behavioral health. They maybe are then scheduled for this diagnostic assessment with a CDC social worker, so with a master's level clinician at our affiliated autism center. And then based on a determination of that diagnostic assessment, they may then be referred for that full evaluation. So an IDA is what we call it here, which is an interdisciplinary assessment. And so that's where they're getting seen by a speech therapist, a psychologist, and usually a medical provider from DBP. And that usually takes place over the course of 2 sessions, and then they then get scheduled back for feedback. So from start to finish, kind of from first concern to like the feedback appointment, this is taking about 270 days. And of course, what we know is that the majority of patients who are referred to behavioral health or specialty care really don't successfully link with services. There's a lot of barriers, there's lots of hoops that families and patients have to kind of jump through or go through in order to actually get those appointments, really just starting with the process of getting a phone call. So that referral in our system at least they'd get called by behavioral health intake, who would do a triage to help make that next appointment or get them on that appropriate wait list. And where a lot of patients and families kind of fall off or fall through the cracks is after that referral is placed. And so then they're not getting linked successfully. Maybe they missed the phone call, they're not calling back, voicemail box is full. I'm sure you guys are all aware of all of those barriers that go along with having to make phone calls to kind of really get patients and families connected. And so what happens is that it's really just this revolving door, especially in primary care, the patients and families usually are just coming back with similar concerns about they're not talking, they're not eating, they're not sleeping well, there's aggressive behaviors or sensory sensitivities that are going on, or maybe even they're getting kicked out of daycare because of some of these associated behaviors. And so it can be frustrating, not only for patients and families, which is for sure frustrating, but also for the providers who are in the primary care setting, kind of seeing this revolving door kind of happen and seeing families kind of getting stuck in this process. We also know that there are disparities in access to evaluations as well as access to treatment for patients from minoritized backgrounds. And here in Columbus at our primary care centers, we're really strategically placed in areas and neighborhoods that are serving a predominantly underserved patient population. My clinic in particular serves a large immigrant and refugee population. A large population of our families are either non-English proficient or have English maybe as a second language, but not their primary language, or request an interpreter. So this led us to really try and develop something that we could do within our integrated primary care setting. And so this all started with a collaboration with our autism affiliated center, the CDC, our primary care network, as well as our developmental and behavioral pediatrics colleagues, and really developed our evaluation kind of based off of the Autism Learning Health Network's diagnostic algorithm. And so it is an abbreviated evaluation. The goal is really to provide a brief evaluation that is sufficient to really make the diagnosis and make a confident and competent diagnosis, and to help families connect with the services and early intervention that they really need. And so in the context of this evaluation, we're doing a clinical interview. Of course, we're doing a chart review. Most of them have an MChat on file, or we're getting that in the context of that initial primary care appointment where the first concern may have been noted. We're doing a CARS, the Childhood Autism Rating Scale, a DSM-5 autism checklist. When able, we're doing report measures like the ASRS or the Autism Spectrum Rating Scale or the CBCL. In addition, we recently added an autism diagnostic interview revise, the ADIR. And that was really because we've gone through a couple iterations with which Becca is going to talk a little bit more about. But here in Ohio, you either need an ADIR or an ADOS in order to connect with the County Board of Developmental Disabilities and with some of the services and agencies that are offering ABA. So at times, you know, in the midst of the pandemic, a CARS was kind of good enough. But now that we're not in that pandemic state anymore, they are kind of going back to requiring that ADIR or the ADOS. And I'm going to hand it off to Becca now.
All right. And so when we were thinking about who would be appropriate for this pathway, it was really important to us, to Ty's earlier point, that we were evaluating kids that we felt like comfortable and competent to be able to make this evaluation in primary care. Because what we didn't want to have happen is we're having a bunch of kids that are coming to us and then we're still not sure, and then we're sending them back to the CDC, and then really we're just creating another barrier for a family. And of course, there are kids that just aren't appropriate to be evaluated in the primary care setting, kids that really need that full team evaluation. So the kids that we're seeing through our pathway typically are between 18 months and 4 years of age that have high suspicion for autism. So that's usually due to behaviors observed during the exam with the pediatrician, provider report, MChat scores. Then we do the survey for well-being in young children. So that's kind of our general developmental screener. Patients with limited language use, and then patients who have a relatively uncomplicated medical and psychiatric history. And then this is who is likely not appropriate. The reason we added that is because we always welcome, if providers aren't sure, for them to reach out to us to kind of see, if there's a patient that, might not initially seem like they meet the criteria, but, if we have a 17-month-old who has really significant symptoms, who has a sibling with autism, who parents have really high suspicion, provider has really high suspicion. These aren't hard and fast rules. It's not a disqualifier, but just when we're thinking about who is our target population. So again, patients that likely might not be appropriate are those kids under 18 months that are over 5, because often once kids hit 5, we really want to make sure they're getting a full developmental evaluation that might include cognitive or academic testing, which, within primary care, we're not able to provide that level of evaluation, history of significant abuse or neglect, and then medical history that may complicate the presentation. So the child was born extremely premature, has significant vision or hearing concerns, and might, again, benefit from that full team evaluation. They're likely not appropriate for our pathway. Go to the next slide, Ty. Thank you. So this is kind of our phase 1. So we really worked again with the CDC to kind of pull kids that might be, waiting on that traditional pathway, or kids we saw in clinic that we used to refer to that traditional pathway onto our pathway. And what it looked like initially is the patient was seen in primary care. Ideally, if there is one of our integrated psychologists in that clinic, they're able to get that warm handoff and see the family as well, talk about the pathway, and get them scheduled at that visit. So the referral is placed, but they're also ideally scheduled while they're still in the pediatrician's office. So family knows here's a day and time you're coming back, and that saves that phone call step that, again, we lose a lot of families. So then we'll do the evaluation in the primary care setting. So patients are able to come back to their home clinic, where they see their pediatrician. We have a lot of families that even getting to the CDC, our Child Development Center, is a huge barrier, because if it's, hard to get to for families, that, is a barrier to making it to the visit. So they're able to be seen in their home clinic. We do the evaluation. Family completes a preliminary feedback within IPC psychology. And the reason we call it preliminary is not that, again, oftentimes we were very confident about the diagnosis, but we were missing that ADIR. And again, our goal was not to give a bunch of families an autism diagnosis and a report that they couldn't do anything with. Like, we want to make sure that this diagnosis is helping families access services. So then they would all have to go to the Child Development Center to get that ADIR, and then they would have a final version of the report that they could give to our local county board of developmental disabilities, to any ABA agencies, to the schools. So then that's when they would have the final report in their hand. So again, lessons learned. Ideally, we really want to try to schedule patients for follow-up while they're in clinic. So I'll talk a little bit about this, but we found that anytime we're able to actually schedule the patient for their next appointment while they're physically in the clinic, that really helped with the completion of the pathway, because again, that's saving that step for, they need to be called. We need to assume while they're called that they can answer, that they have time to talk, they have time to look at their calendar and do all those pieces. So just by scheduling them, we know that that really helps. The next part was, again, we felt like we were confident in making the diagnosis for a majority of families. So again, a lot of the kids that were coming in, we felt very confident, even, having not yet done the ADIR, we felt like, based on our interview with the family, behavior observations of the child, we were very confident this child was going to meet criteria for autism, and we're really sending them for the ADIR in order to make sure they were having, a gold standard report that was able to help them link to services. And so we were able to, with the Child Development Center, get training in the ADIR. So that way we were able to do that as part of the evaluation, which again removed a barrier for the family. So our current pathway is now patients seen in primary care. We schedule that next appointment. We do the evaluation in the primary care setting, including the ADIR. Family comes back to do the feedback with IPC psychology. They're able to get that final copy of the report and then can use that to access services. And one thing we are proud of right now is that for families that come to that initial appointment, so again, I wish I could say we were 97% completion for every patient referred, but it's really once that they come to that first appointment, they're 97% likely to complete the whole pathway. So we're still kind of thinking and problem solving about ways we can increase the percentage of families who were referred who complete the pathway. But again, we have some clinics that don't have integrated psychology in them. So we are relying on families to be called, to be scheduled, to referred. And we know just in general in behavioral health, anytime we can have that warm handoff in primary care, it increases the likelihood that family's going to come. And so just continuing to think about ways we can continue to improve that number. And then that's just showing our average time. So again, we have average time for that traditional pathway was 270 days. Our pathway average time is 42 days. And I will say that number does include some outliers, because we do have some families that, like I can think of families that come back in a couple months for their next well-child check and weren't able to finish the pathway, but they're open to finishing that evaluation and we're able to get it done when they come back. And so again, for most families, we're able to refer, do the evaluation 2 weeks later. They have, they have the feedback, but of course, there are barriers, things that come up for families. And so our average is about 42 days. And so kind of thinking about continuing opportunities, we definitely recognize the importance of consulting with local and state resources. We had a meeting with the representatives from the county board to make sure that our reports were going to help kids link to services and make sure that we weren't leaving anything out, because for a while, to Ty's point, that the CARS was sufficient. And so we wanted to talk with county board and see, because if that was the case, we don't want to keep families in clinic longer than they need to be, but, getting that feedback that we do need the ADIR. If you don't have the ADIR in the report, then even if they're able to link, there's going to need to be another evaluation for the family in a couple of years, and saying, no, our goal is to reduce barriers for these families that are encountering more barriers. So we'll just go ahead and make sure we add that. Also thinking about agencies providing intervention and treatment. That's something that we're continuing to think about. I think one of our next steps in the pathway is going to be thinking more about, okay, we're doing a great job diagnosing kids with autism and getting them, that report that helps them access services. Want to make sure all these kids now are accessing those services. So that's kind of our next step. Thinking about consulting with caregivers of autistic children, of, what are better ways that, from the family facing side, how do they feel like the, evaluation goes? They feel like there's things that we could be doing to help make the visit, easier. Like, are we, creating any more barriers that we're not thinking of? What are barriers you're encountering in accessing interventions? And so continuing to think about that. And then also considering ways to utilize our electronic health records, which I think we have just a few more slides, and that's one thing that is on there. So like Ty mentioned, we are presenting at the CHFA conference in October. If you'd like to learn more kind of about our pathway, about who's completing the pathway, more kind of specific data, we'll be talking a little bit more about that. So we'd love for you guys to stop by if you'll be at the conference. We're continuing to think about ways to streamline these evaluations. So how can we use our Epic as our electronic health record system to streamline visits? So, for example, when a child is diagnosed, we have a bunch of referrals we have to put in. I will give Ty a huge shout out because she worked very hard with our electronic health record system. It was a lot of steps, but we now have a smart set, so I can just type in IPC autism and all those referrals populate. And so again, that's just saving time and being able to make sure that, no steps are getting missed, and continuing to think about ways to reduce barriers to care. Like I mentioned earlier, we found that anytime we're able to schedule a family for an appointment while they're in the clinic, we know that that reduces a barrier. And so, some of our intervention services that our Autism Center offers, one service is like a one-time appointment where families able to get questions about the report answered to help them link to Franklin County Board, Adult Disability, Special Needs Preschool. It's just a single appointment. And we're now able to, for families who are interested, to get that appointment scheduled during the feedback. So again, that helps families not have to wait for another phone call. So like Ty said, I know that was a really quick summary of our pathway. We're really kind of excited about where it is and where it's going, but definitely welcome questions and hope to see many of your faces in October when we present. We'll be presenting, with a couple, different presentation, I lied. We'll be seeing you at CHFA, and we're happy to answer any questions that you have.
Awesome, thank you so much. So let's just we can open it up to the group for any questions or comments people have. You can place it in the chat, or you can unmute and ask away.
Thanks, Jada.
Read.
I have a question. I don't know if I'm on. I think I unmuted myself. So this is Colby Bootson. I'm in Memphis, and I'm just curious the decision making on using the ADIR rather than the ADOS.
Sure. I think it was for a couple of reasons. Ty, you can feel free to chime in as well. One, I think, again, we're really trying to use the ADIR in young kids. And so for kids who are under 4, it's much quicker to do the toddler algorithm ADIR than the ADOS. And then I think too, from a resource perspective, we're very fortunate that we have psychologists doing these evaluations. And we just counted, Ty, how many clinics is it in?
Clinics. No, 7 clinics, soon to be 9.
Yes. And so I think even just thinking about like the number of ADOS kits that we would be needing to kind of make sure we're serving all the clinics, I think from a resource perspective, having the ADIR has been helpful because we're able to just pull it up no matter what clinic that we're in. And so I think those were probably some of the big reasons. I don't know, Ty, if you have other.
I think another part of it was from also the pandemic, because you can do the ADIR in the context of a telehealth visit, because it really is just parent report or caregiver report. And so you can do the ADIR in a telehealth visit and still do a little bit of observation with the child. But unlike the ADOS, which really wasn't able to be administered when a lot of the protective PPE and things like that, and in the midst of the pandemic was occurring, it was a nice switch for us. And I also think this allows us an opportunity that if maybe we evaluate a child in primary care who maybe wasn't totally appropriate, it's happened, I'm kind of have a hard time saying no. And so sometimes I'm like, sure, I'll do it. And it turns out to be way trickier than I had anticipated. And maybe I've done the ADIR, then I am able to refer them over to our affiliated autism center where an ADOS can be done. So it just kind of helps kind of provide another next step that can be done with at our affiliated autism center that maybe isn't really an appropriate level of care within the context of an integrated primary care visit.
There was a question in the chat, and it looks like Tanya may have answered it, but do you have to be a licensed psychologist to administer the ADOS?
I am under the impression that similar to what Tanya has said, like I know we have psychometricians that do the ADOS, but then as far as like billing and report writing and interpretation, that's done by a licensed psychologist. And so, yes, I agree with that point. But again, everyone who's doing these evaluations in our clinic, we are all either licensed psychologists or fellows working under, psychology fellows working under a licensed psychologist.
On that point, I guess, how long does it take to do the assessment in the clinic? I mean, thinking about within a primary care setting. So what's kind of the average length, or what kind of you booking in terms of an appointment length?
We are trying really hard to keep this in a 60-minute appointment. And so usually if you're doing the ADIR and it's with this target population that maybe has limited language functioning and limited language skills, you know, the ADIR can maybe take just about really 25 to 30 minutes once you get pretty fluid with it. And then that gives us time to do the clinical interview and kind of the CARs and doing a little bit of that observation kind of within that 60-minute time frame as well. And maybe just gathering some more information from a clinical interview. I think it's easier to do it all within that 45, 60-minute appointment when you're able to have that warm handoff. So it is really helpful if I'm consulted on a child with these suspected autism concerns and can go kind of touch base, do a little bit of that questioning. You know, if you're familiar with the ADIR, I sometimes like ask about language level so that I know they're coded a 2 instead of a 1 and what my ADIR is going to kind of look like in that evaluation. So they're scheduled for 60-minute appointments. And then the feedback is a separate appointment, which is generally a 30-minute appointment.
Well, and it looks like Lisa had asked a question about that kind of report. Can you speak about the report you're generating?
Yeah, I'd say our goal is like similar to the evaluation is to have all of the information in the report without it being a super lengthy report. So we have, it'll have the results from the ADIR, the CARs, parent rating forms. If parents were able to fill out the ASRS and CBCL, that will be in the report. Like a brief developmental history, social history, and then kind of different sections that we take the information from the ADIR and put kind of in the symptomatology sections for autism, and then all the recommendations. Again, we really try to be streamlined with our recommendations of, what are the really important things that the families need to know kind of for next steps. And so those are usually all the pieces that are in the report. That's something else we've been working on, seeing ways to kind of streamline in EPIC. So having like a report template that has those pieces that just kind of make that process a little bit quicker, because what we found is, which I think makes sense given, I think during the pandemic that a lot of kids, maybe were missing some of those well checks and, started coming to clinic, and a lot of parents have concerns. And given the number of clinics that we have at Nationwide, some weeks you can be doing a lot of reports. And so, within primary care psychology, we don't have designated report writing time. To answer that other question, we are also doing integrated care kind of while we're doing these appointments. And so thinking about, what are ways we can make sure that families are receiving, a high quality report, because it is, it's not just like a symptom checklist report, like they're getting, examples and, those pieces. And so it's I like to think that it's a pretty thorough report, but also thinking about, what can we do to streamline it?
It's about, I don't know, 4 pages.
Other questions, comments people have? Curious, I guess, how maybe other members of kind of the team are involved, pediatricians. It kind of sounds like maybe they're kind of sending you the kiddos to evaluate, but thinking a little bit of their kind of feedback loop or other ways that team members are involved in this.
I think that's one of my favorite things about this pathway, honestly, is that it's taken me, not just within primary care and at Nationwide Children's Hospital Primary Care lives in pediatric psychology, but been able to kind of develop partnerships and collaborations kind of outside of primary care network, outside of pediatric psychology, and with our developmental behavioral pediatricians and with our autism affiliated colleagues. I think and even with care coordinators and care navigators, I think that's been really meaningful to me to kind of be able to kind of step outside of my bubble a little bit. Our primary care providers are really involved and really invested in this because they're seeing the progress. They're seeing the benefit of and even, we haven't looked at this, but perhaps even a reduction in utilization and frequency of appointments because they've got that diagnosis and they're linked with the right people, ideally, who can help provide these interventions that are really going to target the need and the level of care that's really necessary and warranted. And so they're not just popping back in that revolving door of primary care to, again, kind of discuss the concerns with language or picky eating and sleep. Now, that, of course, still happens. We're seeing them for those well child checks, and that still happens. But I think the primary care providers are really seeing the benefit of this and now just want us doing this like all the time, full time in every single clinic, and even like outside of our academic affiliated primary care network outside in the community as well. So we're thinking about ways we can kind of expand our reach and maybe provide even additional support outside of our internal primary care network.
So.
And I think that's a good point too that you make, Ty, that our goal too is all of our kiddos that we're evaluating on our pathway are still hopefully making it to our autism center, that they're getting, again, that like coordination appointment to go over the report, and they're linking with developmental behavioral pediatrics. But the idea is instead of doing it all in one visit as part of that interdisciplinary diagnostic assessment, they meet with us and they're able to still link with DBPs just kind of later on. And so I think that's been a nice partnership that we're still working with the DBP department to make sure that they're getting scheduled.
The other thing I forgot to mention is that I think it's like helping to increase education with providers about autism and how to more effectively and kind of help support our patients and families with autism or have children with autism. Becca's been working kind of on some next steps in terms of like, how can we have more autism friendly ASD office visits? And so are there ways we can modify the environment? Can we do early morning or first session appointments time, and even developing a social story that is hopefully soon to be kind of distributed to kind of help support within our primary care network. So it's been cool to see that like motivation and initiative from the primary care providers to be like, I really want to be involved in this and I want to learn different ways to kind of help support, and how can I be a better user and consumer and help kind of make sure that this is an appropriate referral so that they're not getting stuck in our system or falling through the cracks in some way.
That's great. And I guess as you were talking, I had another question, and maybe you are presenting at CFHA on this, so I don't want you to have to give away totally, but thinking in terms of some of the data that you've been collecting, like obviously you have kind of the wait time, but other things in the EHR, or maybe even kind of like patient feedback on the process.
Yeah, we do have some exciting like outcome data and more demographic data, and that will probably be part of the CFHA presentation. So I don't want to spoil it. But I can say in 2022, we did 226 evaluations over our 7 integrated clinics that we're in. So we're seeing a large number of patients, and I think that's only going to continue to expand as we kind of formalize and really streamline this pathway within our internal primary care network. And we are seeing a really diverse patient population. I think off the top of my head, 86% identify as non-Caucasian, and about 36% identify as having a language other than English as their primary language, and 24% just for that 2022 data required or requested to have an interpreter present during that evaluation. And that really differs from the population that our affiliated autism center is seeing. So we're kind of reaching a different patient population, a more diverse patient population. And really helping to get them linked and get them kind of started with this process as soon as possible. And I think the national average age of diagnosis is like right around 4 years of age, and our average is right around 30 months, I think.
Oh, yeah, I agree. Awesome stats.
And Becca, I know Becca mentioned that about 97%, like once they attend that evaluation, about 97% complete the pathway. Our number from referral to completion is right around 78%. So not too far off, but we are having some patients who, maybe aren't able to have the evaluation completed in their medical home. And that's really what we'd love to kind of strive towards, because that's really, I think, the biggest impact of this pathway.
And I think to Ty's earlier point with that number within 7 clinics, we're doing the evaluation within 7 clinics, but again, trying to remove barriers. If a family, goes to a primary clinic that doesn't have an integrated psychologist, if the family is willing to go to another clinic, that's not an exclusion criteria. So like we have a clinic about probably like 15 minutes, maybe not even from my clinic, and they don't have an integrated psychologist right now. If the family is willing to come here for the visit, we, discuss with the pediatrician, the family, can come here for the evaluation. So that number, the 200, I already forget it, Ty, but the 200 and some evaluations that we've done, that's kind of all across, our PCN.
And we have 14 primary care clinics within our primary care network, and we're integrated into 7 currently and soon to be 9.
That's awesome. And so we'll definitely look out for that that presentation at CFHA to see kind of the updated numbers.
It's on Friday.
Cool.
And we are working on writing up our pathway. Our hope is that we'll have a good official write up and piece that of course we're hoping will be published, but we would be happy to share. A work in progress.
Awesome. Any other questions or comments for Becca and Ty? Well, we want to thank you both for sharing your pathway and the great work that you're doing. I think we all learned a lot. And so we are going to segue over to the research corner, and Jonathan's going to take it away, talks a little bit about an article related to this, so we can see if that sparks some more discussion. Thanks to you both.
Yes, thank you both for the presentation. I learned a lot myself, and I think this article does tie nicely to that. So thank you for providing it as well. Let me find this. Sorry, 1 sec. It's all messed up for some reason. Okay. All right. So this article looks at the concordance of a diagnosis of autism spectrum disorder made by pediatricians versus a multidisciplinary specialist team. And as the presentation pointed out, wait times can be very long for an ASD diagnosis or assessment. And so, the question is, can general pediatricians be able to diagnose autism spectrum disorder? So the objective of this article was to compare and look at the accuracy of pediatricians versus a multidisciplinary team. So the study was conducted in Canada between 2016 and 2020, and the participants included 17 general pediatricians, a multidisciplinary team, which included a developmental pediatrician, psychologist, and a psychometrist. And it included 106 children younger than 5.5. They were referred for a developmental concern and without an existing diagnosis of autism spectrum disorder. And so the research design is children were either randomly allocated to either seeing the multidisciplinary team first before the pediatrician visit, or the other way, after the pediatrician visit, and always happened within 4 weeks before or after. The multidisciplinary team assessment included the ADOS-2 and the Mullen Scales of Early Learning, which looks at intellectual development, school readiness, cognitive ability, motor development. And so both the pediatrician and the multidisciplinary team both conducted blind assessments to determine if the child had ASD, did not have ASD, to give a different diagnosis, refer to a subspecialist, or just watch and wait. And then they rated their level of certainty on a 5-point Likert scale. As far as the results, 72 of the participants, 68% received a diagnosis of ASD by the multidisciplinary team. And when it comes to sensitivity and specificity, pediatrician assessments compared to the multidisciplinary team. So pediatricians correctly identify children with autism spectrum disorder 75% of the time. And they correctly identified children without autism spectrum disorder 79% of the time. As far as positive predictive value, when the pediatrician thought autism spectrum disorder was present, the team agreed 89% of the time. When the pediatrician did not think ASD was present, the team agreed only 60% of the time. And further results in terms of accuracy, so higher pediatrician certainty was associated with increased autism spectrum disorder diagnosis accuracy, and higher visual reception subscale developmental skills, whether the child speaking versus non-speaking abilities and white race, was associated with lower autism spectrum disorder diagnosis accuracy. And interestingly, child age, gender, and ADOS-2 scores were not significantly associated with accuracy. And really the only predictor, the significant factor, was whether the child had a sibling with autism. So this article suggests evidence that basically this high positive predictive value for children assessed as having, let me rephrase that. This study found that a high positive predictive value for children assessed as having autism spectrum disorder by pediatricians, indicating that these pediatricians may be able to diagnose when they feel certain. However, when agreement was lower for cases when pediatricians did not think the child had autism spectrum disorder, so maybe caution is necessary before ruling that out any further. All right. Thank you. Any questions, anyone? Or I'm sure Ty or Rebecca could probably answer these better as well.
Thanks, Jonathan. That's an interesting article, and I guess kind of a different take on this in terms of having pediatricians assess. I may have missed this, and we can kind of, I guess, start opening up to conversation, but did they report on how the pediatricians assessed for autism?
Off the top of my memory, I'm bringing it up right now. So it says here, conducted their ASD assessment as they typically would. That's what I can read further here. So
that might just be kind of their typical practice. They may not have reported specifically on what that looked like.
Yeah, I don't see it here.
That was my impression as well, that it was just like, there's no specific intervention, no specific assessment, just, assess as you normally would if you had concerns for autism, and then, then say what you would do and your level of confidence, and then we'll, send them on.
It's interesting, and I don't know how you tease this apart, but that the the confidence piece is kind of the predictor, and I don't know how much they're feeding off of making the right diagnosis, but when they're confident, they're getting it right. And so trying to kind of tease that apart, or thinking about it in a way of like what contributes to their confidence, and being able to kind of make that accurate assessment.
So I found it exciting and reassuring too, because we're getting a lot of referrals from pediatricians, and actually I think kind of in part when we were looking at this paper, we've added that to our like referral process, not a Likert scale, but a percentage of, you know, how confident do you feel like this child has autism? And we're interested to kind of see kind of the data from that of, you know, pediatrician kind of confidence, because similarly, you know, our pediatricians, when you know, when the child has an elevated MCHAT or they have concerns, they might talk a little bit about what autism is or broach the topic somewhat, but, you know, aren't asking tons of follow-up questions. But again, the goal for our pathway would be, hopefully we're evaluating and capturing some of the kids that pediatricians feel pretty confident have autism, kind of based on their, you know, interaction with the child during the well-child check and reviewing the screeners with parent. And so to me, I'm like, hopefully this is a, you know, good sign, because that's kind of the target population that we're trying to get.
I think it'll also be interesting, like I added that into a referral system because, you know, we're doing the MCHAT and the MCHAT follow-up, but pretty routinely now within our system at the 24-month well-child check. But within our system, because we are seeing such a diverse patient population, the MCHAT's not always a great predictor. And so, you know, we often have MCHATs of 0, and it's like, no, I'm 100% confident in this diagnosis, or an MCHAT of 17, or I just had an MCHAT of 9, and I was like, no, I have zero confidence in this. I have no confidence in this diagnosis. I don't think that this child meets criteria for autism. And so it might be interesting to also kind of look at some of that data as well to see how well our MCHAT is actually predicting like the confidence level and who's getting referred to us. And is that a really acceptable, kind of feasible way to kind of help identify and target the referral like population?
Yeah, I mean, and I think I guess I had a similar like that's kind of impressed in terms of kind of the concordance rates, and you don't know exactly kind of what they're doing. It's just whatever their kind of particular practice is in terms of assessing, you know, autism. But I was surprised by that, and it is kind of exciting. Jada says, I would think the cases, yeah, the obvious cases, that makes sense. And the more ambiguous ones would be the one that they'd want to kind of refer out.
No, I definitely agree. And I think that's something that we're like thinking about for next steps of like provider education, because I agree that I think, you know, when you think about referring everyone, that can be hard, because if you have kids that, you know, maybe pretty clearly with a couple of follow-up questions, you aren't concerned with autism, but for pediatricians who maybe don't have that extra like layer of knowledge to feel confident, of course, they don't want to miss autism. And so they might over refer, or the opposite. You know, I feel like it's a double-edged sword in the sense that you're like, oh, I know the wait list is so long because there's so many kids. I'm just not going to refer anyone and kind of continue to watch because I'm really not sure. And so I definitely agree with that I think those like ambiguous cases, I think are some time, you know, we can think about what can we do to help our pediatrician colleagues like help with that. I think that's why it's really nice when there is a psychologist in the clinic, because we can help with that. But how can we help pediatricians with that? Or, you know, or how can we help pediatricians know that kind of what do you recommend while you're waiting? Like, you know, for us in Ohio, we have county board of developmental disabilities, and, you know, for kids that are 3, they might meet criteria even without an autism diagnosis, depending on their level of need. And so kind of thinking about, you know, what, you know, how and what patients are able to access while they're waiting too. So I definitely agree with that.
I know we just have a few minutes left, and I'm kind of curious if other people have attempted to kind of implement a pathway, or what do they do when autism comes into their clinic? Are the pediatricians, you know, or the PCPs, are they the one who are diagnosing? How are you involved? What are people's processes now, if anyone's willing to share? Or maybe we're not doing a whole lot. Yeah, and I think that Lori's point of limited options tend to refer and support, and I know agree that this is helpful. Previous clinics that I've worked in, I think has been in the similar stage of, you know, we have to refer and there's a long wait list. And I think there was questions of, you know, how can we support the kiddos in the interim? And I don't think there were options. I don't think we had considered at least doing any type of assessment. And so it's kind of exciting to see how you all streamline things, and also exciting to look at this data to think that there was that pediatricians and some of the PCP data too. Nice. MChat, Ages and Stages resource.
Yeah, I will say, you know, Becca and I debated about developmental psychology versus pediatric psychology in primary care. And I think Becca has been trained as a developmental psychologist. So we both come into this with kind of a passion and a love for working with this patient population. Like, I can't say that all of our psychologists in our integrated primary care program love doing these evaluations. And so I think it, you know, it does take perhaps a, you know, a particular setting and like a passion and different resources to really be able to make this successful. Because I think assessment in primary care is just not something that, you know, in our setting at least, not something that we've really thought of as being something that we could feasibly and sustainably do in the context of an integrated primary care setting. And I think we're trying to kind of think outside of the box and maybe show that it is something that we could do. And it's actually a really great service to our patients and our families, but also our providers and our clinic staff as well.
Well, on that note, I would agree. And so really great service and helping us kind of, at least our members, think a little bit about, you know, yeah, ways you can do assessment, you can streamline this and get these kiddos connected to resources and getting access. I think the biggest, one of the other kind of big takeaways is kind of your ability to get the kiddos who maybe wouldn't otherwise make it to the, you know, multidisciplinary team assessment. So this is exciting stuff. And so I want to, again, thank you both for coming and sharing what you're doing. And thanks to everyone here who participated and asked questions. And I think we can wrap up. So thanks, everybody.
Yeah, hopefully we'll see some of you at the conference. And again, if not, feel free to reach out to either of us with any questions you have in the meantime. Always happy to talk through things and collaborate. So
thank you so much.
Thanks.
Thank you, everyone.
Bye, everyone.